Hello, everyone, and thank you for joining. Welcome to today's Catalight webinar, How Parent-Mediated ABA Helps Parents, Providers, and Payers Succeed. One size doesn't fit all. I'm Chris Larson, a reporter for Behavioral Health Business. I've been covering the healthcare sector since 2016, and I'm excited to be moderating our conversation today. During this webinar, we'll discuss Catalight's perspective that parent-mediated applied behavioral analysis, or ABA, can help children, parents, and the industry as a whole. We'll save 15 minutes at the end of today's webinar for audience Q&A. So please enter your questions into the Q&A window during the webinar. Our panel will answer as many as possible after our discussion. In the resources widget, you'll find a PDF file that you can download about why autistic children may need fewer hours of treatment than previously thought, and a press release about a study supporting that fewer hours of ABA may be appropriate for some. You'll also find a post-webinar survey. Please take 1 minute after we wrap up to share your feedback on today's webinar. Joining us today are Catalight's Vice President of Clinical Excellence, Lindsey Sneed, Ph.D. and BCBA-D, and Karen Bears, Ph.D., Clinical Director of the Seattle Children's Autism Center and Associate Professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington. Lindsey and Karen, can you tell us a little bit more about your backgrounds and roles? And Lindsey, let's go ahead and start with you.
Yeah. Hi, everyone. I'm so happy to be here talking about this very important topic, something that's near and dear to my heart. I'm Lindsey Sneed. I'm a clinical psychologist and a behavior analyst. I've been working in the field of intellectual and developmental disabilities for the last 17 years. And for 12 of those years, I've been at Catalight, now serving as the vice president, where I get to support clinical standards and our research initiatives.
Hi, everyone. I'm Karen Bears. Very excited to be here as well. A little bit more about myself. I am a clinical psychologist by training. As Chris mentioned, I'm in the Department of Psychiatry and Behavioral Sciences at UW. My work is focused on the development, research, and implementation of parenting interventions for autistic youth with challenging behaviors. When I talk about challenging behaviors, I'm talking about things like meltdowns, physical or verbal aggression, difficulties with transitions, and destructive behavior. And as part of my work, I also lead the Ruby Clinic at the Seattle Children's Autism Center. And this is where we're providing Ruby as an outpatient service for families in the state of Washington.
Awesome. I'm so glad to have you guys here. Let's go ahead and get into the subject matter at hand. Lindsey, why don't you go ahead and start us off? Let's address this question first. What do we mean by parent-mediated ABA?
Yeah, so parent-mediated ABA falls under the larger umbrella of parent-mediated interventions. And PMIs, like parent-mediated intervention based on applied behavior analysis, these are evidence-based procedures really across the board for children, including children with intellectual and developmental disabilities, including autism spectrum disorder. So in a PMI, when you're thinking about it kind of more largely, what it looks like is a licensed or certified clinician is working directly with the caregiver, the parent, and learning the specific skills associated with the respective treatment model. It can be a naturalistic developmental model or a behavioral intervention model, which is mostly what we'll be chatting about today. So parents are taught some of the basic foundational skills that may be necessary to support their understanding of what they're being taught to go forward and teach their child. And then what happens after they get some basic foundation is their clinical team, usually a board certified behavior analyst or a psychologist, work directly with the caregivers in implementing goals that they've identified are important for their family or for their child, that are based on their familial values. In this model, the clinicians usually model the specific skills that we're aiming to teach with that parent for their child. We have the parent model the skills, then we have the parent practice the skills with their child, and then the clinicians provide feedback supporting their efficacy and being able to implement the model of care. So really at large, that's what a parent-mediated intervention is. There's different kinds of parent-mediated interventions. But again, today we're talking about parent-mediated ABA, which is the one I'm most familiar with. And what I love about most PMIs is they're happening in the child's most natural environment, usually in a home. and usually with their most natural first teacher, which is their parent or caregiver. It doesn't always have to happen in a home. Sometimes families want it to happen in a clinic, which is fine. But I think the biggest thing is that they have the child with intellectual and developmental disabilities has that natural rapport with their caregiver. So really provides like a first robust step in moving forward and attaining new skills, teaching parents how to deal with difficult behaviors. Yeah, it's a really great option for families.
I gotcha. That's a great foundation to get us started. Now, Karen, let's build on that foundation a little bit. What are the benefits of parent-mediated ABA or the parent-mediated therapies?
Yeah. So I'm going to talk about the practical benefits later, just this general idea that parent training as an intervention can really, because it's a lower intensity intervention, can open access to care. So we'll talk about that a little bit later. But I want to start by talking about the personal benefit of parent-mediated interventions. And it's this idea that Lindsey was referencing, that we're targeting really behaviors and goals that are personal to the family, that have meaning to the family and the parent. So I'm talking about things like the morning routine, just getting out the door on time for school, or the bedtime routine, or thinking about meal times, or toileting challenges, sleep challenges, or maybe it's having success when you're going to the family gathering. These are the things that our families are struggling with, that they're asking for support, and that these parent-mediated interventions can really help directly work with them to help them meet these goals. What I want to acknowledge is that this is not always easy work or straightforward work, but there are things that can really help to facilitate this process. And what I want to focus on in that is this idea that when we're doing parent-mediated interventions, we're talking about a collaborative care approach to this. Mm-hmm. The way that I like to think about it is that we acknowledge that the parent is the expert in their family and in their child. Nobody knows their child better than them. And so we want to value and honor that expertise in their family and their child. And then we can come in as the provider with an expertise in particular skills or strategies. And we think about the therapeutic process in these parent-mediated interventions as this collaborative co-creation of a treatment plan for this family. So we talk about expert guided on the family side and expert guided on the provider side to come together. From the provider side, what we do want to bring in are things like motivational interviewing, really thinking about adult education principles, and also collaborative problem solving. So how can we work together to figure things out? The beauty and the benefit of these approaches is that we end up with really positive and powerful and impactful outcomes in a relatively short period of time. That we're really working on practical goals for the family that can impact family functioning, the child's behavior, and the relationships within the family. And just to give a really kind of a simple example, I was working with a family that was really struggling with the bedtime routine. They had 3 kiddos. One was autistic, and then the 2 siblings. And they talked about this routine taking like 3 hours. And there was a lot ingrained in this routine that they really valued story time and just spending time together during this, but it was also taking a lot of time. And so the work was kind of going through the different strategies in Ruby in this particular case, and figuring out how we can, on one hand, meet the goals of the bedtime routine, getting the teeth brushed and the jammies on, and honoring that time together as a family with the story time, et cetera, but also maybe shortening up it a bit. And what the family talked about is at the end, they had this really lovely family routine. But the parents also talked about, and then we also got like 1 or 2 hours to ourselves after the kids were in bed, something that we hadn't been able to have prior to the work. So it's just one really lovely example of how this very targeted, personalized work that is designed to meet family needs. And then our job is to really help collaborate with the family and support those goals.
I gotcha. Those are very valuable insights. Want to shout out real quick that we do have our first question in the Q&A, and invite everybody again to submit their questions into the Q&A box so we can address those at the end of the presentation. So if there's a question that you have that you want us to address and you hear it in the moment, go ahead and take a moment and put it into the Q&A box so we can get to it, so that we can get to it at the end of the presentation. Okay, Lindsey, let's go to you with our next question. What interest have you seen in parent-mediated ABA among families, and are they aware that this is an option?
Historically, in my time in the field, I would say parents are not as aware of it. I think parent-mediated interventions are actually like a long-held intervention that have been around for a long time, particularly in the realm of applied behavior analysis, where you have the psychologist coming to work with the parents, in the particular areas that are important to him. But more recently, we've seen a kind of a resurgence in more research being developed, research coming out, agencies adopting parent-mediated models. And with that, we're seeing caregivers become more aware of it. Usually what I'm seeing right now is parents hear parent-mediated intervention and they think a little bit more about what we might call parent training or parent education. So in a parent education model, it's really like an information exchange where we're providing parents information, hoping that they'll digest the information. And in some cases, that's actually really, really beneficial and probably what the family needs. But in other cases, a lot of cases, it's usually not enough to support what is specifically going on. So a parent-mediated intervention is where we're equipping parents with specific skills, speaking to what Karen was speaking about just a second ago, with skills that are important for their family, things that are going to be pivotal, things that they get to implement as a family that are going to help their family well-being, family quality of life, help their child, help them as caregivers, and help siblings if siblings are in the house. And Karen has actually done a lot of research in this particular area, looking at like parent education alone versus Ruby, which Ruby is a parent-mediated intervention based on applied behavior analysis. And time again, Dr. Baer's studies have demonstrated how effective PMIs or Ruby is over just general parent training in and of itself, because we're equipping parents in these specific skills. Parents are leaving with knowledge, they're leaving equipped, they're leaving with self-efficacy. So what we're seeing is with this coming more and more to the surface, more people becoming aware, families are becoming more aware of it. And for some families, that is what they go to. I say by and large at Catalight, where I work, the majority of our patients that come in do go into like a 3-tier model of service where they're working with a paraprofessional. But about 25% are going into a parent-mediated model. And just to like take it home, I have a story that was really meaningful to me. A number of years ago, I gave a diagnosis of autism spectrum disorder to a child. And the mom, when I gave the diagnosis, she was, she was really actually upset, but not because of the diagnosis of autism. They had long suspected that their child had autism. What she was upset about is her brother has autism. And in the 90s, he had been receiving 30 to 40 hours a week of ABA. And while there was some benefit, it also had a lot of impact on their family life. And so when we started talking about treatment options or interventions, care services available for the family, what she was upset about is the potential that she would have to go into this high-hour program. And when we talked about the different models of care that were available and she heard about parent-mediated, she was thrilled because like really for her, it wasn't even necessarily about the parent-mediated ABA. It was about having the choice to choose something different for her family. So I think like as families are getting more excited about having choices in their care options, they're getting really excited, and they just knowing that there's other options and they don't have to go really into this one size fits all model.
I gotcha. Very clear benefits on the the micro individual level, but let's talk about at the macro level. How can parent-mediated ABA benefit provider organizations and payer organizations?
Yeah. I'll say something that we've really seen with diversifying our models is just increasing access to care. We're able to meet more individuals as we're individualizing their care more specifically to what they're needing, what they're wanting, and really aligning with evidence-based practice. Within the framework of evidence-based practice, we look at 3 things. We look at the best available research support, we look at the client or family preferences, and we look at the clinician's training or skill sets. And so when all 3 of those are in place, we have evidence-based practice. But when one of those aren't in place, we no longer have evidence-based practice. So by having options, we have more availability, more access to different evidence-based options that are really going to fit the family's needs. So we're having like another benefit is diversity in care. So we have diversity in care options. We're able to meet more individuals where they're at. And again, I just can't emphasize enough the access, like we're just able to see more people. And then the other benefit from a clinician perspective who works for the providers is there's more diversity in what our caseloads look like. There's more diversity in what we're doing. So we aren't having like this mundane experience by doing the same thing over and over again, but we're getting to practice different skills clinically, which that may not be interesting to everyone, but that's really a benefit for me. I really like practicing in different modalities, be it in a 3-tier model, in a parent-mediated model, or even in a coaching model. So I think the diversity and access to care, we can't speak enough about that.
I gotcha. And let's talk a little bit more about parents. And Karen, let's go to you with these 2 questions. How can this benefit parents, and in what ways does parent-mediated ABA and similar therapies help them?
That's a great question. And I'll speak of my experience running the Ruby program with families in particular. And what I often experience is that parents come into treatment and have a decent sense of what they want for themselves, for their family, for their child. But they're coming to treatment because they're a little stuck on how to get there. And they might say things like, I'm trying this with the sibling and it's working fine, but when I try this with my autistic son or daughter, something's not clicking. So I have goals, I just don't know how to get there. And just a really kind of simple case example, I had a family I was working with. When they talked about their morning routine, it was the parent, setting the kiddo up on the couch, putting a TV tray up, putting the breakfast on the tray, turning the TV on, and then feeding and dressing her child while he watched his morning cartoons. And she talked about how, this is how I navigate my morning routine right now. I can't be late to work again. My kiddo needs to get to school on time. And I want my child to be independent, but my attempts to do so really were challenging. I was met with challenging behaviors when I try to help support him to be independent in these dressing skills, as an example. So they know what they want, but they're just struggling on how to get there. And so this idea that when we work directly with the parents, we're creating opportunities for direct parent empowerment, and that we're setting them up to be the agent of change for their child, which is a really, really powerful therapeutic approach. One thing I want to throw out that's really important to understand is it's a misnomer about parent training. There are times when providers will say, I'm trying to do parent training with the family and they don't want it. Or I tell them, to do it and they, they're turning me down. And there's some really interesting research that's come out of the state of Michigan focused on families receiving early intervention services through the state, Medicaid funded. And they really went in and looked at the provider experience and the family experience. And what they found was providers saying, parents don't want this. But when they went to the families, what the families say is, I do want this. But what I really want is the good stuff. Kind of coming in every couple of weeks and checking in, doing kind of basic case management or problem of the week. That's not helping me feel like I'm getting anywhere. I want the stuff that's going to help make tomorrow better. And then when they were given access to that type of services, they were very, very happy, very satisfied with that type of care. So it's not as simple as just saying, do parent work. It's about doing quality, high fidelity, evidence-based parenting interventions. And when our families get that, they really are satisfied with that level of care. The last thing I want to talk about is just what we're trying to accomplish in helping parents through these parent-mediated interventions. A fundamental that we talk about in the Ruby program is this idea that behavior is communication. When your child is screaming, they're trying to tell you something. When they run out of the room, they're trying to tell you something. And so we want to kind of dig into understanding, why the behavior is happening. And when I hear, behavioral challenges occurring, I like to talk with parents about it just being missed communication, that the way you're, wanting to let your child know what you might want of them or what's coming up isn't in alignment with how that child may need to understand what's expected, and vice versa. The child may struggle with, how they can communicate what they want and need. So this idea that we're going in there and utilizing strategies, evidence-based practices to help kind of bridge communication between a parent and child can really have a profound impact. And I'll end with a case example, as I seem to be prone to do here. I was working with a family where their morning routine regularly involved meltdowns, and it started with the simple question of, what do you want for breakfast? Which is a question that we ask for kids like every single day, all across the world. But for this child, that question was actually really difficult for them to answer because they were not good at kind of the task of thinking, well, do I want cereal? Do I want pancakes? Do I want waffles? It was a really frustrating question for him to be able to answer. So then the parent would kind of repeat it, and then she started throwing out ideas. Do you want waffles? Do you want pancakes? Do you want cereal? And that was overwhelming him. And finally, the mom said, I finally waited, and he said I wanted pancakes. And wouldn't you know, Karen, I didn't have pancakes that day. And that resulted in a meltdown. We changed this interaction from a verbal back and forth to a visual choice board. It just had the child's choices of pancakes versus waffles versus cereal visually displayed for this child. So it took this interaction that was a verbal back and forth and turned it into a visual support that aligned with how that child communicated best. And when the mom started implementing that strategy, not surprisingly, the behavioral challenges went away. It was just a matter of changing how they communicated with one another and using those evidence-based practices, visual supports in this case, to help the family get there. So just really, and sometimes simple strategies can be what really helps parents get where they want to go and help children to be able to really successfully navigate their daily routines and their family interactions.
Those are great insights. And Lindsey, let's go to you with this question. What can the industry as a whole, payers and providers alike, do to advocate for more use of parent-mediated ABA?
Yeah, that's a really good question. Because I think there's a lot to be done, and it's probably going to take time. I think something as simple as this, like kind of like grassroots work, just like demonstrating, like talking to people about the effectiveness of it. I know Karen and myself in various capacities, we try and do a lot of trainings, go to conferences, training, equipping clinicians. And so I think like just spreading the word in this way is really important. I think amplifying the research that's already been done and continuing to do research. There's a lot of research in parent-mediated interventions. And what I'm finding is a lot of people just aren't aware of it. They aren't aware that it's there. But there's a reason why it's an evidence-based treatment because of the empirical foundation that is there. So spreading the empirical foundation, I think is really, really, really important. I think another thing is I've talked to clinicians around the country, and oftentimes what I hear is a barrier. And I primarily work in California and Hawaii, so I am most familiar with California's systems. And so I recognize for me as a clinician, that is a barrier that I have, because what I hear from other clinicians is there's difficulty in billing processes. And so I think updating billing and CPT codes to support this model of care would be really, really helpful, because I'm hearing that is like a big, big barrier for individuals, is being able to actually bill for this program. They want the programs, but there is not a way to actually implement it to the degree of fidelity that we're talking about right now. So I think that's something that needs to be done. And I think another thing is a lot of clinicians don't have as much training working with parents and caregivers. And so I think like providing additional training, support, supervision, consultation for those psychologists and behavior analysts who do feel really confident and are able to work effectively with parents, training the next generation of clinicians in the field to work more effectively with parents. It's really a fantastic way to see really big positive change in a family and a child. So for me as a clinician, it's something I get really excited about doing, but I also recognize that not all clinicians feel really comfortable with that. And so just continuing to provide trainings and supports, creating opportunities for consultation with clinicians who have that experience is really, really important, so that we can really equip the next generation of clinicians to support parents and families in this way. Because for a lot of, I could speak to behavior analysts specifically, for a lot of behavior analysts, it is a new and different way to implement interventions than what most behavior analysts are used to. So just equipping, I think any way we can equip and improve our clinicians' self-efficacy in implementing parent-mediated interventions would go a long way.
I got you. And you talked about some of the issues with reaching fidelity. Lindsey, let me ask it this way. Is there industry pushback to this idea of parents doing ABA, and why would that be?
Yeah, no, I think there is, and I sometimes I get I'm such a big advocate for it. I'm such a big proponent for parent-mediated interventions that I have to remember that not everybody is, and I think the idea is that for some people it feels so different. Speaking to that, like, what can we do to change things? I think it feels like a different model. Even though it's something that has actually been around for a long time. Applied behavior analysis is evidence-based because of the procedures that are within it, and parents have been doing these things for a long time. But it is different than what has typically been done, I would say, in the last 20 years. And so change can be hard. Change can be hard for individuals. It can be hard for clinicians. It can be hard, I mean, for a nation, for insurance agencies, right? There's a lot of things that are stakeholders in this that can lead to industry pushback. And so that's one thing, is it just that change, and it takes a lot of work and momentum to get to this point. And then speaking to the other thing I spoke about in the previous question is just providing and equipping clinicians to engage in this work. Karen mentioned a little bit ago about the use of motivational interviewing. At Catalight, for our clinicians that go through our parent-mediated intervention training programs, we also put them through a training of motivational interviewing because it's an evidence-based methodology for increasing chances of behavioral change in an individual, and it's really, really, really effective with parents. And so, but that's an additional training that you need to receive, right? And so it's not something that's inherent in these clinical training programs, not all of them, I should say. In some of them, it definitely is there. But motivational interviewing is a great skill in the clinician's tool belt to help them feel more confident in their ability to work with parents specifically. Motivational interviewing is an evidence-based intervention. It's been used in various different methodologies shown to be effective. So we see that, additional training is needed. I think another pushback comes from like the long held belief that you need 30, 40 hours a week of ABA for it to be effective. And we're just seeing in more recent research in the last 10 years that that's just not the case. We're consistently seeing that high hours is not a predictor for positive treatment outcome. There are some hours that are necessary, absolutely. Karen and I were talking earlier about how probably 10 hours is probably better than 5, but we don't know that magic number. But there was a study done in 2021 comparing 25 to 15 hours, and both groups did really well. There wasn't any differences between the groups, and other research coming out. So, but parent-mediated ABA does really kind of not go against, but is different than that long-held belief that you need lots of like direct hours. And at the same time, it's interesting because as parents, we're always interacting with our children, and we are present in the most pivotal times of the day: morning routine, dinner time routines, nighttime routines. Those are typically like 3 of the most difficult times. And so parents actually are there to learn these things in lots of pivotal hours, and can be trained to implement behavioral procedures with their child in a way that's natural for the family. But it still does go, it is different from that high hour belief that's been long held. And for us at Catalight, I know last year into earlier this year, there was this thought that we were paying parents to be RBTs. There is definitely an ethical difficulty for a clinician to pay a parent to be an RBT, because it creates this whole difficulty with a dual relationship, which is 100% understandable. And so I know there is pushback with that, believing that we at Catalight were paying parents, which we're not. We don't pay parents to be their own child's RBT. We're simply teaching parents how to parent their child differently. So I do know that that created a lot of difficulty too within the field, thinking that we had to pay parents, which is frankly not the case. And I actually think diminishes the motivation of the parents to even engage in these really fantastic programs.
I gotcha. So shifting gears just a little bit, Karen, what other treatments involve parents in the intellectual and developmental disability space, and what have been the benefits of some of those treatments?
Yeah, so I'll start that question with the acknowledgement that our families are, by design, having to navigate very complex and varied needs for their autistic or IDD youth, right? And that includes navigating complex, multifaceted, and often fragmented service systems. In fact, there's some research that suggests that any one point in time, a family may be navigating between 5 to 7 different independent services at a time, and that number actually goes up with the complexity of their child's needs. So there's this, we have to acknowledge that parents are essentially required to become experts in things like care coordination, service navigation, advocacy, intervention implementation. So the question is, how do we support families? How do we create space for them to learn all the things that they need to do to be able to most effectively navigate those complex needs? And I think that's where we've seen this really lovely emergence in support pathways for families. And actually, Lindsey talked about 2 of them. There's the parent education pathway, which is really, I think about it as kind of like knowledge focus. How do we build their understanding of their child's diagnosis and service needs, et cetera, versus the treatment or intervention focus, where we're really helping parents to learn the strategies so they can directly impact their child's care or implement strategies that can help support their child. And then there's this third new arm that I'm very, very excited about that I'm currently calling parent-focused interventions. And these are interventions that are designed to support the parent directly. So to kind of go back to those 3 again, we've got psychoeducation, knowledge focused. I like to say that it's kind of a necessary but not necessarily sufficient arm of the treatment options for families. Again, they're learning about the diagnosis and service options. And when we think about modalities for this, we're talking about things like webinars or podcasts or books or classes, like all the ways that parents can get information to just learn how to better understand their child and support their child. On the treatment side, or the parent-mediated intervention side, this is where we kind of break things down into parent-mediated interventions for core symptoms. And that could be things like language or communication, play, et cetera, versus parent-mediated interventions for commonly co-occurring conditions. These are things that are not required for a diagnosis, but are often commonly seen with children that have an autism diagnosis. And that's actually where Ruby falls, as an aside. We are a parent-mediated intervention for co-occurring challenging behaviors. But I also think about parent-mediated interventions in this bucket for things like feeding difficulties or sleep challenges or toileting. Again, they're things that we commonly see, but don't necessarily aren't part of the diagnostic criteria. And so we have parent psychoeducation, parent-mediated, and then to go back to that third category of parent-focused. There's this analogy out there that we oftentimes hear about with airplanes, that when the oxygen mask comes down, that the adult's supposed to put the mask on before they put the mask on their child. And I think it's a really apropos analogy when we think about our families that are, again, having to navigate so much. We know our families are some of the most stressed parents out there. So while we do all this work talking about how they can support their child, where are we also bringing into the conversation how they can support themselves? And so that's why I say I'm very pleased that there's this new, I say within the last 5 years, emergence or highlighting of interventions that are just designed to directly support our parents. The big ones that I've been hearing about are things like mindfulness interventions or acceptance and commitment therapy, where again, it's about how to support the family or the parent so they can in turn help support their child.
I gotcha. Now, Lindsey, Catalight has recognized an opportunity for the industry in parent-mediated ABA. Could you please talk a little bit more about what exactly the opportunity overall is?
Yeah. So back in 2017, I was asked to start doing a literature review on parent-mediated interventions. And, you know, I had been trained as a behavior analyst, and I worked most of my time directly with RBTs and doing some parent training as well. And so when I was asked to do this literature review, I was like, okay, that I can't imagine there's going to be a lot. But then when I started diving into it, I was like, oh my gosh, there's actually so much literature supporting this model of care. And at that time, we were having a lot of families say, you know, that what you're offering is not meeting my family's needs. What other options do you have? So from the literature review, we established the evidence foundation for parent-mediated ABA specifically. And we started developing a program, and we accepted our first parent-mediated client at one of our affiliate partners, Easter Seals, in early of 2018. So we had one client. Fast forward, 6 years now, and now we have, I don't know, I think maybe about 5,000 of our patients in parent-mediated care because we saw it be so successful. And success in a lot of different ways. Success for the child, we're seeing amazing outcomes for our children that are receiving this care across the age span. So from early childhood to youth age in various capacities, really focusing on what are the areas that they need support in. Like what Karen was saying, like there could be a focused parent-mediated intervention on challenging behavior. We adopted Ruby, for example, a few years ago. So we're seeing success on the child, and we're seeing success on the parents' end, where our families are leaving with greater self-efficacy, greater understanding in their ability to effectively parent their own child. So in 2022, Dr. Samuelson, who's our chief clinical officer here, and we published a study that was comparing parent-mediated ABA to a 3-tier ABA model on the parent outcomes specifically. And what we found is parental self-efficacy significantly improved at a greater degree than those parents who were in a paraprofessional delivered model. In the paraprofessional delivered model, just to say, the children also did make significant progress, but not the same, like it wasn't the same for parents. So we're seeing parents having these amazing outcomes. So that was really exciting. We're also seeing shorter lengths of stay for our families that are in parent-mediated treatments. Parents are getting equipped, and I can't remember exactly what the length of stay is, maybe around 20 months or so. But usually it's around 20 months, and then parents moving on, they may come back if something else comes up that they need support in. But the episodes of care are generally shorter. Another benefit is consistently, we send out satisfaction surveys to all of our families throughout our network. And consistently, all of our services, 3-tier ABA, parent-mediated ABA, parent training, social skills group, they do have high satisfaction scores. But the group with the highest satisfaction is parents who are in our parent-mediated intervention. So we're seeing this high satisfaction. So we're seeing all these great outcomes, shorter length of stay, good child outcomes, good parent outcomes, good satisfaction. But then we're also seeing diversity in treatment options. So we're speaking to what I was talking about a little bit ago, having somebody come in and be able to say, here's your choices based on where your family's at, based on where your child is at, and just being able to offer families something different that may fit their family needs better than an RBT delivered model. Now, the majority of our patients are in a 3-tier model. So I don't want to say that like we don't think positively of that too. A lot of families are coming in for that, but we also have a large number of families who are coming in wanting something a little bit different. And so that's the beauty of a parent-mediated intervention. So we're having these diversity in treatment options. Another big opportunity here is it's cost saving for families. It has like families, if it's insurance funded, they have a copay. And so with co-payments, there's less co-payments because there isn't an RBT coming into the home. So we're seeing significant cost savings for families. And then as it's just becoming more available, there's more understanding about parent-mediated options, parent-mediated ABA. We're just seeing more families coming in wanting that service. So speaking to the importance of evidence-based practices, like being able to offer the families what they're seeking in their treatment, care, service for their child, whatever it is. And then just like overall, we're just seeing it be a very, very effective model for families, for the individuals with IDD, for providers, for payers, and for clinicians. So we see it as like a really win-win. It's for me as a clinician, like I don't understand much of the operations side of things. I'm primarily looking at child and family outcomes, and I'm just really excited about the results that we're seeing, which are really, really positive.
I gotcha. So let's go ahead and transition to the Q&A portion of the presentation. So one of the questions we got here is very practical. What if both parents are working full-time?
Do you want to take this one, Karen, or do you want me to?
Sure. Well, and I do want to kind of create a frame of reference for me that I tend to be a provider that works with families that don't have access to ABA. They're the ones that are on the wait list for ABA. I know Lindsey and I have had a lot of these conversations about the difference between services in the state of California versus the state of Washington, or frankly, most states that are out there. My experience with a lot of families is that they have been recommended ABA, but they're waiting for it. And I hear about a 1, 2, 3, I've heard 3 years of a wait for ABA. So when that's to kind of put a frame of reference around what I think about with parent training, which is, again, a traditional outpatient model of care while the family is waiting for services. And so the idea that we have two families that are working, that actually works fine in the model of care that I do because it's an outpatient service. So Ruby, as an example, is a 1 hour a week intervention. And so that means if parents are working, we can talk about, the 8 a.m. appointment or the 5 p.m. appointment to meet work schedules or over their lunch break. I did see there was a question also just asking about like telehealth based services. And I'll tie it in here because this is another example. Let's say that parent 1 is in their office and then parent 2 is in their office. Both of those are 30 miles away from each other and 30 miles away from me, right? So the expectation is that I don't need the families to drive in and do the appointment for an hour and then go back to work and now miss like 3 hours of work just for a 1 hour appointment. What we know with Ruby, for example, and we have data to support this, that it works just as effective as a telehealth model of care. So it is this idea that even with working parents, they can use their lunch break, they can use that hour before they go to work, and they can, pull up at their work desk or from their home to join the visit, have that 1 hour of care, and then go about their work day. I will say my favorite example, every so often I do have families that do actually have ABA while they're still engaging in Ruby with me. And one of my favorite cases, I had the ABA therapist joining in, and the husband was joining in from his work, and the wife was joining in from her home, and grandma was joining in from her house. And all 4 of us were together doing this Ruby session via telehealth, but also creating really good bridging and continuity of care across the family members. Yeah.
I was going to say too, like that, a really big shift, I think, for the industry was the pandemic. The pandemic had a lot of negative things, but I'll say as a clinician, a positive thing that came out of it is the utility of telehealth and it becoming more acknowledged as a really effective way to implement services. So far, like in the studies that I've seen, the comparison of face-to-face to telehealth delivered models of care, particularly in parent-mediated interventions, is really, really effective. Like both are equally effective. We're also seeing this in like your general therapeutic models too, where telehealth is as effective as the face-to-face models, which really created this opportunity to provide services to families in a telehealth option that is a valid way to implement interventions. Another thing about parents working full-time is I actually think there's more flexibility in parent-mediated interventions. In an RBT delivered model, I mean, the parents have to be there learning the skills too anyway. A caregiver has to be present. So the same problem is still there if both parents are working and you're getting an RBT delivered model, because we need to be providing that parent training. So what we're seeing is a lot of times that utility of the telehealth option, having a family call in via telehealth. Maybe the clinician is at the family's home and one of the caregivers is out, and they're calling in that way. Or there's more options in like when the session occurs, I think is really important. So it was interesting in the pandemic, because we had a lot of stories where families were already receiving parent-mediated interventions, but all of it was happening in the home, and one of the caregivers was working. And we heard stories of families being like, well, now everyone's together on telehealth, like the example Karen was just saying, and families are benefiting from that model. So I don't think it's 100% possible all the time, but I would say, it actually hasn't come up in practical experience as a big barrier.
I gotcha. Now, quick kind of gear shift to another subject matter that's presented to us in the Q&A. Let me just go ahead and read this question. Would love to understand how payers are reacting to this trend, and the question asker is considering starting a practice that is focused on parent-mediated interventions. So overall, what is the reaction from the payer side to these types of interventions?
I'll say this. I would say this is probably not my area of expertise. I'm
Sure.
really much a clinician, but I know some things. I think payers, again, the difficulty is with the billing models, right? Like that we need to see more changes in how billing occurs. But I mean, payers are excited because of the general shorter length of stay that we're seeing with good outcomes. So with some of the payers that I know I've talked to, that's been a really, really big benefit. But I will acknowledge that is not my primary job and not something I do regularly. So I probably couldn't speak to that super well.
I gotcha. And Karen, anything to add there?
Oh, I would try to, I'm a psychologist, and so I bill CPT codes. So when we're talking about parent-mediated interventions or parent training, that is, particularly for challenging behaviors, that is actually an intervention focus that has been out for decades. We have models like parent-child interaction therapy, Incredible Years, Triple P, et cetera, that I think have kind of blazed the trail around CPT codes that can be really useful for these types of parenting programs. And there's billing codes that are established, like family therapy with child, family therapy without child. So I'll be honest, I've had less difficulties with billing for the work that I do, but I also acknowledge that I'm using CPT codes, which I think has a little more of a history and a runway of using parent-focused interventions.
I gotcha. Now, from the clinician perspective, there's a question about engaging with BCBAs in this model. So the question is, how do you get BCBAs to buy into the parent-mediated model when they may not have been trained to engage with families in this way?
I get really excited about this topic because I was too once a skeptical BCBA who got totally bought in after I saw the positive outcomes. And I would say I work with a lot of clinicians who do both models of care. And so I have worked with clinicians who are implementing primarily RBT-based intervention. And then I work with clinicians who are implementing primarily parent-mediated interventions. And so I can speak to the fact that for the clinicians who are implementing parent-mediated interventions, after you have like your first successful client, which is usually the first client that you serve because it is really effective, they're like sold on it. I have so many BCBAs who are like, I will never like do any other model besides parent-mediated intervention, because really you're going directly to the source. We're going directly to the source, equipping them, training them, seeing the positive outcomes, for the parents and their child. And it's from a behavioral perspective, it's really self-reinforcing for me as a clinician, because I'm seeing these positive outcomes, engaging with parents. Not that it's always easy. Like, we do have to navigate difficult conversations, implement like sometimes procedures that are difficult to understand. And so walking parents through these things. But usually after BCBAs get into it, my experience has been is that they love it. I've actually never talked to a behavior analyst who has said something otherwise than that. But I think, like, as far as training and equipping, like, I hope things like this are really supportive and helpful. I know that's something Karen and I are both really, really motivated by, is like supporting clinicians and training them and equipping them to work with parents. At Catalight, we have various training programs for clinicians to get more experience implementing parent-mediated interventions, working directly with clinicians. And then just to say, like, consultation is really helpful, reaching out for consultation with other behavior analysts or psychologists who can support you. But one of the big things for me was just having a great supervisor teach me how to engage with parents in a more effective way. So really capitalizing on your supervisor can be really, really helpful.
I gotcha. And Karen, any thoughts on helping BCBAs approach doing this kind of work? Or even any clinician for that matter, if not
yeah. Just starting with the idea that parents are people, and really good parent training is just like conversations with the family about the ideas, the principles, and then working with them to figure out, how they might want to apply them. In fact, I think really good parent-mediated interventions is not about you having to go in as the expert that's going to wave the wand with all the phenomenal solutions. It's really about talking with the parent about possibilities and really helping lead them to the solutions, which can be a really cool and powerful thing. But it also kind of takes the onus about like having to be the expert in all the solutions. I say that as someone who does a lot of training of new providers. So like master's level students, students in, Ph.D. programs that are kind of scared about this idea of doing this work. And I just say, if you just go in there and focus on, it's just a conversation. You're learning about their needs. You're sharing ideas and helping them come up with what's going to work for them. It's not as onerous as it might feel like. I think the biggest thing we talk about are just the common buy-in challenges, like how do you deal with the crisis of the week or when caregivers don't see eye to eye. But that's, again, as Lindsey was saying, good consultation can provide support around navigating some of those really common barriers that we see in this work.
I gotcha. And let's get a little more specific. It's another Q&A question that we have that's at least parallel to that, or maybe further down the logical line of that is, what outcome measures are you using when you're implementing these types of models, right? That might be something that helps illustrate for us here what, the impact could be. And then also just to kind of further on the conversation, help people who are clinicians but may not necessarily be engaging with these models today to get a better idea of what the work looks like. So outcome measures, what are they in this case?
Do you want to go first, Karen?
Sure. I'll talk about the ones that I use. Certainly we're going to do, quantitative ratings of challenging behavior. So we have in the past used measures like the aberrant behavior checklist. I'm gravitating now to a couple of new measures called the Emotion Dysregulation Inventory and the Open Source Challenging Behavior Scale. But honestly, one of my favorite measures to use is what's called the Youth Top Problems. It's a measure that allows the parent to define what their top priorities are in treatment. And then included in that measure is a quantitative rating scale of on a scale of 0 to 4, how much of a problem is it? And then using that scale to assess change over time. What's nice about that measure is it allows for, again, that idiosyncratic assessment of parent priorities in treatment and then assessing change over time. We also like to look at changes in adaptive behavior. So for Ruby, for example, some of the most powerful outcomes are not just the reduction in challenging behavior, but that we actually see significant improvements in daily living skills. And so whether it's something like the Vineland or the ABAS, also having a measure of functioning adaptive skills can be really important because we absolutely can see change in those measures as well.
and I'll echo some of those. We definitely use the Vineland as an adaptive measure, seeing significant improvement in those. But we have some other outcome measures that we use as well. We use a parental stress scale, a parental self-efficacy scale. We also, in 2020, started developing family well-being scale and youth well-being scale. Our family well-being scale was published in JAD earlier this year. And so we're monitoring well-being of the family as well as the individual when they're able to answer the well-being questions themselves. And then goal attainment is another area that we evaluate. We particularly use the goal attainment scale as our methodology at Catalight to look at goal attainment overall. And then for it can become more nuanced depending on the program, like our Compass B program, Compass Behavioral. That's a coaching program for autistic youth and adults. And for that, we don't use the Vineland. What we use that is specific goals and youth or adult well-being. So depending on the program, we might use a different outcome measure, because it's looking at something more specific to that program and to that individual.
I gotcha. So we're in the last 5 minutes of our program so far. Just one more question and very brief answers if we can, just to make sure we get everybody out of here on time. Let me just read this question. Karen mentioned that the Ruby model provides 1 hour of treatment per week. What is the duration of treatment? And then Lindsey, how many hours per week of PMI are your clients receiving and for how long?
Yeah.
Karen, why don't you go ahead and hear from you first?
Oh, sure. In Ruby, so we published our outcomes in that on that intervention in JAMA, and in that particular study, we set 16 weeks to get through 11 core sessions of content plus up to 2 supplemental sessions. I'm excited to report that we've recently looked at data of 150 families that have been seen at the Seattle Children's Autism Center. So these are, we'll call them the real world families as opposed to the ones that we might, enroll in a clinical trial. And what we're seeing is the average length of treatment is 14 weeks. So I do actually have a number to share for how it's working and how long it's taking in clinical practice.
And for our parent-mediated ABA intervention, the average hours per month are 4 hours per month for the board certified behavior analyst and 8 hours to 9 hours per month for our mid-level clinician. That could be a BCBA-D. It could be a master's level clinician with additional experience in applied behavior analysis, or somebody with a bachelor's degree and additional experience with applied behavior analysis. So on average, about 12 hours per month total clinician time. The study that I published last year, that was about the number, and that's usually the average number that we're seeing at Catalight as a whole. And the average duration is somewhere between 20 and 22 months. I can't remember the exact number, but that's the average duration.
I gotcha. And we are up on time, folks. I want to thank everybody for joining us for today's sponsored webinar. I want to especially thank Dr. Lindsey Sneed and Dr. Karen Bears. And I want to thank them especially for partnering with us on such an essential topic in the autism when it comes to autism spectrum disorder care. Please remember to explore the article and press release that is in the resources tab or button, and take 1 minute to share your experiences with us today on this webinar through the survey link, also in the resources widget. Your feedback to us is essential. Your feedback is essential to improving our programming. I'm Chris Larson, reporter for Behavioral Health Business. We'll see you next time.